A very good evening. I am Dr. Nikhil Khattar, and I'll be talking on diagnosis and treatment of female urethral strictures. So, regarding female urethral caliber, what is a normal caliber and what is the narrow urethra, which will actually require a reconstruction? The normal caliber in adult Western women is around 22 French, and that in adult Asian women is around 23 French that has been studied. But the controversy is regarding narrow urethra. The definitions range from less than 10 French to less than 20 French. And it is still not clear what actually will require a reconstruction. But most studies on urethral reconstruction take the caliber cutoff of less than 14 French. But recently, uh, there was a study from JIPMER where even urethral calibration, even with 14 French, does not diagnose a urethral stricture. That was the conclusion of the study, where even if successful the successful urethral calibration, still if there is whitish mucosal discoloration and poor rigidity, poor distensibility on cystoscope, then that urethra requires a reconstruction. That was the conclusion of the study. So it is not yet clear what is the role of calibration in diagnosis of female urethral stricture. So what about video urodynamics? These are pictures of two women with proven urodynamic bladder outlet obstruction, high pressure, low flow, and a dilated posterior urethra on dilated proximal urethra on micturating film. But the first female on urethroscopy shows a very poor quality urethral mucosa and a narrow caliber, whereas the second woman did not show any narrowing and the mucosa was absolutely healthy. So the first woman had a stricture, and with the similar findings on video urodynamics, the second woman was diagnosed with a dysfunctional voiding. So a visual demonstration of an anatomical luminal narrowing on urethroscopy is the gold standard. That is what is required before we proceed for any urethral reconstruction. How should that be done? If we see that if we use a conventional cystoscope with a 30-degree lens, then most of the water fluid, the irrigant fluid generally leaks out and does not distend the urethra, and uh, a narrowing may be missed. You can see here. Whereas in the next video, in the same urethra, we can see that ring. This is because we are using a 0-degree scope with a flat end, which does not allow any irrigant to leak, and we see end on. So urethral inspection is actually very important whenever we are doing scopy for a female with voiding dysfunction. So once diagnosed, whether dilatation should be done or reconstruction should be done. So these are the findings from this systematic review published very recently, where urethral dilatation had success rate of only about 50%. And it was concluded that although a single time urethral dilatation in some cases is advisable, but definitely multiple urethral dilatations do not add anything to the outcome. And if possible, the urethra should be reconstructed. Moreover, dilatations should not be done in females who do not have stricture. So once we have decided that a urethra requires reconstruction, then we have multiple choices how actually to do it. There is no one surgery proven till now that is superior over the other. There is dorsal onlay, there is ventral onlay, there is dorsal inlay, ventral inlay, there are local tissue flaps, there are grafts. And then, but because there are so many options, we have to choose. There are some anatomical considerations that we have to have in mind while choosing our approach. Where is the female sphincter is first and foremost, and how long can we split? Can we split the both the sphincters right up to the bladder neck? What provides the bed to the graft if we use a graft? And is there any effect on the sexuality of the woman after the surgery is performed? So this is a histopathological slide of a newborn female, where female urethra, where we can see the external urethral sphincter area, and most of the bulk is anteriorly. Same is confirmed on MRI films of adult women, that most of the bulk is anteriorly and less is posteriorly, that is ventrally towards the vaginal side. And this is the external sphincter, the components of the external sphincter. Uh, and this is the bladder neck, which the bladder neck sphincter is said to be a passive sphincter with which is there because of detrusor fibers interlacing with each other. Then secondly, there is no corpus spongiosum around the female urethra, unlike in males, where when we put buccal graft for male urethral strictures, then there is corpus spongiosum or tunica albuginea over which the graft is placed and from where it takes its nourishment. But in females, there is no corpus spongiosum. These are pictures of mm, uh, female external genitalia in congenital adrenal hyperplasia and of varying severity from left to right. This and the same is then seen on MRI. If we see the formation of these structures, there is no corpus spongiosum here in the, this is the female control, where the bulbar tissue is, the bulbs are lying on either side of the vagina. Whereas as more and more virilization occurs, the bulb forms here in the midline. Otherwise, this corpus spongiosum was not there. This is the dissected spongiosal tissue in a female, which is lying anterior to the urethra, between the urethra and the clitoris. And then secondly, contrary to the view, popular view, that clitoral body forms the bed for the dorsal graft, but that also is not the case. As we can see this figure from our own book, this is drawn by Rishi, and we can see that looking from below, the corporal structures form bed only for the distal half of urethra, not for the proximal half. Proximal half of the graft actually is supported just by fibrofatty tissue. And clitoral nerves do not get damaged in the dorsal dissection because they are lying underneath the clitoral structures, the bodies, and our dissection is generally limited to the midline. So with all this in mind, we can choose our approach. This is anterior or dorsal onlay graft urethroplasty, where we split the urethra in the midline. This is from our own publication from RML. And once we have gone beyond the stricture, a graft is placed. In this case, it was vaginal graft, which I do not use anymore. I use buccal grafts nowadays, and this is the completed picture. This is ventral or posterior onlay graft urethroplasty. Again, figures are from our own book, where this the inverted U-shaped incision is given on the vagina and the flap is dropped down. The stricturotomy is given, and a graft is placed and non-overlapping closure is done. So whether to choose a dorsal or a ventral approach, dorsal approach avoids fistula and preserves the plane for future incontinence surgery. And but the ventral approach has minimal urethral mobilization. There is less pain and less blood loss, but there are chances that a ventral approach may form fistula. Whereas in dorsal approach, because the bulk of the sphincter is on the dorsal aspect or anterior aspect. So there may be a little higher chance of developing de novo stress urinary incontinence. But these differences are very, very minimal, as we'll see later in the outcomes slide. These are inlay approaches. This is the dorsal inlay, where we in inlay approaches we uh, do the stricturotomy from within the lumen. We do not divide the wall of the urethra, and the graft is placed after dividing. This is anterior or dorsal inlay. This is posterior or ventral inlay, and this is an overlapping dorsal and ventral inlay. These are the sites from where flaps can be taken. These figures are from Dr. Dalela's chapter in our own book. This is the anterior vaginal wall that can be taken for flap. The vestibular tissue can be taken for flap, or the labia minora tissue can also be used as flap. Here, this is typical Blandy like approach, where the ventral vaginal, the anterior vaginal wall is used as a flap in the stricturotomy. This is the Blandy procedure, and this is the Orandi procedure, just like in male urethra, where the vaginal tissue is interned towards the stricturotomy and form the substitution for the urethra. Whereas this is Montorsi flap from the vestibular tissue that is used mainly for the distal strictures. And this is the island raised from labia minora tissue over a pedicle, and that can be used there. This is the surgical photograph, where this is the island taken on the pedicle that can be used as a dorsal onlay. These are the success rates. The dorsal approach has been used most commonly, and with the pooled success rate of around 88%. Ventral approaches have a slightly better but almost equal success rate without any significant difference. The buccal mucosa urethroplasty and vaginal graft both have been used with almost equal success rates. And the flap urethroplasties are mostly described for distal urethral strictures with a very good success rate, and whereas the urethral dilatation has a very poor success rate. So the dorsal approach is the most common one used. De novo incontinence was slightly higher in dorsal approaches, and sexual function does not deteriorate and rather improves after dorsal urethroplasty, that we had concluded from our study from RML. So what makes success after a female urethroplasty? According to literature, there should be no need for any instrumentation. Flow rate should be more than 15, and there should be improvement in quality of life. But if we see here, this is a post-operative 3-month follow-up where the flow rates are very good. The curve is also good. And this is at 4 months. The flow rates are almost similar, but the graph pattern has gone flat. And patient also started complaining of some symptoms. And when we did a scopy, we found that there were flimsy adhesions. So why that happens is because the natural state of female urethra is to stay thrown in folds. And once the catheters are removed after urethroplasty, there is still some healing going on. There are still some sutures which are there to be absorbed later, and they cross adhere to each other, forming flimsy adhesions because of this sphincteractive urethra, unlike in male urethra. And at times, the graft which is placed can even get excluded from the lumen because the spasm is so strong. So if there is the slightest of doubt, slightest of complaint, we recommend that urethroscopy should be performed early if there is any recurrence of symptom, irrespective of the Qmax that we find. So that is all that I had to say. Thank you so much.